Regarding the biologic state of oligometastasis, first pioneered by Dr. Wexelbaum and Dr. Hellman in 1995, continues to evolve. To this end, in 2012, our institution of MD Anderson Cancer Center, supported by the Moonshot Initiative, began a phase 2 randomized study in oligometastatic non-small cell lung cancer in conjunction with the University of Colorado as well as the London, Ontario Cancer Center. Patients who were eligible for this trial had a diagnosis of stage 4 disease and up to 3 metastatic lesions after standard frontline systemic therapy. At this time, standard treatment was defined as at least 4 cycles of platinum doublet chemotherapy or 3 months of EGFR ALK targeted therapy based on whether a relevant molecular alteration was present. Other criteria are listed here. Patients were assigned to one of 2 treatment arms. The first was the standard arm, consisting of maintenance therapy or observation, or denoted as the MTO arm going forward, and the second was the experimental arm, which consisted of LCT or local consolidative therapy, radiation therapy, or surgery to all sites of disease, going forward known as the LCT arm. Here we present the schema of the study with the 2 arms previously described. 3 additional points can be made about the design of the trial. First, the primary endpoint was progression-free survival with secondary endpoints that include overall survival and toxicity. Second, in lieu of stratification, the trial was conducted with the incorporation of balanced randomization based on 5 disease factors listed here. Finally, and importantly, patients were allowed to cross over at the time of progression. That is, patients in the MTO arm could undergo complete LCT at the time of progression if eligible. Furthermore, patients on the LCT arm could again undergo complete LCT if they progressed. The study was powered for a total of 94 randomized patients. We published our initial results of the study in 2016. Notably, the trial was closed early due to a substantial benefit observed in the experimental arm when only 49 patients were randomized. While we observed the expected PFS time in the MTO arm of 3.9 months instead of 4.0 months, the median PFS was 11.9 months in the LCT arm. These results were then supported by a subsequent study published by UT Southwestern in the following year, yielding similar PFS times in 2 analogous cohorts of patients. Since that time, the PFS benefit of consolidated therapy has been demonstrated in at least 4 randomized trials prospectively. While these results are encouraging, the significance of the PFS endpoint has been debated on the grounds that improved PFS is a natural consequence of ablation of known sites of disease. Moreover, it's been suggested that PFS could be a misleading endpoint if the vast majority of patients will ultimately experience aggressive, fulminant failures in distant sites. In our study, it was particularly unknown if the PFS results would translate to an overall survival benefit because, as noted previously, crossover was allowed between treatment arms. Or put another way, it was unclear if late LCT at the time of progression would ultimately lead to similar OS times as early LCT, that which was completed after first-line systemic therapy. The aims of the current update are thus as follows. First, we'll report the final data from our primary endpoint of PFS. Second, we'll update our secondary endpoints as published in the initial analysis of safety and time to new lesion failure. Third, we'll report the overall survival data as these results were immature in our initial publication. Fourth, we'll utilize exploratory analyses that attempt to address the question of early versus late LCT in this patient population. Finally, we'll identify patient characteristics that may portend for improved OS through the implementation of early LCT. Here are the final PFS results for this study. At an extended follow-up of 38.8 months, the median PFS time in the LCT arm was 14.2 months versus 4.4 months in the MTO arm. This outcome retains statistical significance with a p-value of 0.022. With regard to time to new lesion failure, the median time to appearance of new lesions was 14.2 months in the LCT arm and 6.0 months in the MTO arm. This result trended towards but did not maintain statistical significance with increased follow-up time. In addition, there were no additional grade 3 or higher long-term adverse events in either arm. Here we've depicted the OS results for this study. The median OS time in the MTO arm was 17 months, but was 41.2 months in the LCT arm. This OS time translated to a hazard ratio of 0.40 and was statistically significant. In our first exploratory analysis to assess the mechanism behind the statistically significant and substantially improved OS time in the LCT arm, despite the allowance of crossover, we explored the endpoint of survival after progression. We found that patients in the LCT arm had a survival after progression of 37.6 months versus 9.4 months in the MTO arm. Again, this result was statistically significant. We then asked whether the increased survival after progression time was due to the lack of aggressive salvage options in the MTO arm at the time of progression. To answer this question, we first determined what percentage of patients were eligible for complete LCT in each arm at the time of progression, and found that 32% of patients in the LCT arm and 45% of those in the MTO arm underwent this treatment. We then compared patients that had complete LCT at the time of progression, defined as full consolidation, regardless of the treatment arm to which they were originally assigned. We found a trend in the improvement of OS times in those patients that had complete LCT at the time of progression, with a median survival that was not reached, versus 16.4 months in patients who did not undergo complete LCT at that time. To supplement this analysis, we then did a 3-arm comparison, comparing A, the LCT arm, with B, patients in the MTO arm who underwent complete LCT at the time of progression, versus C, patients in the MTO arm who did not undergo complete LCT at the time of progression. This comparison reached statistical significance with median OS times of 41.2 months versus 17 months versus 11.4 months, respectively. We then assessed the same phenomenon in each treatment arm individually. We again found trends, though not statistical significance, in both the LCT and the MTO arms when comparing those patients that did versus did not undergo complete LCT at the time of progression. While we want to emphasize that these analyses were exploratory and in small groups of patients, they suggest that while early LCT is the optimal approach in this setting, late LCT can partially offset the difference between the approaches. However, they also imply that less than 50% of patients will ultimately be candidates for late LCT, and thus that a mechanism for improved OS in early LCT, despite crossover, may be that ablation of all disease is biologically preferred and ultimately not feasible for a large percentage of patients who delay this treatment. Finally, we analyzed pre-randomization disease characteristics and found that N0N1 disease, 0 to 1 METs after frontline systemic therapy, with 0 METs indicating primary tumor only, and the absence of CNS metastases all may be associated with an improvement in the LCT arm. Note that the p-values listed here indicate the interaction terms for the groups being tested. Thus, in conclusion, our study that shows that with long-term follow-up, LCT in patients who do not progress after frontline systemic therapy improves PFS, is associated with an improvement in OS, and showed a trend towards improvement in the time to appearance to new sites of disease. Second, we showed that LCT had acceptable tolerance, and long-term follow-up did not demonstrate further high grade of toxicity in either arm. Third, we showed that survival after progression improved in the LCT arm, with a trend towards improvement in survival with complete LCT at the time of progression, implying that late LCT provides improved OS times compared to MTO alone. However, it is notable that less than half of patients in our study appeared to be eligible for this treatment at the time of progression. Finally, we identified several patient subgroups that appeared to benefit from LCT, with trends towards statistical significance, including those with less metastases after frontline systemic therapy, a lower burden of nodal disease, and the absence of CNS metastases. There were limitations to the results presented in this study. As mentioned previously, this trial was stopped early, and as such, the smaller number of patients complicated subgroup analysis. However, no major imbalances were detected between treatment arms, largely through the incorporation of balanced randomization. Second, a heterogeneity of treatments was delivered on the maintenance therapy arm. While this initial trial did therefore not allow for a granular comparison of specific subsets of patients, the rationale was for a pragmatic design that assessed the overall treatment paradigm of LCT. Finally, the trial was performed prior to the advent of immunotherapy, and with only a small number of patients that had EGFR and ALK alterations. Therefore, it's unclear if these results and conclusions can be extrapolated to these specific patient populations. There are the several potential future directions of this study. First, the results can be expanded with trials that contain larger numbers of patients and that use overall survival as an endpoint, particularly phase 3 trials. Second, while the current study provides strong evidence for the LCD paradigm, given the spectrum of treatments and prognoses in these subsets of lung cancer patients, it would be appropriate to study the effects of LCT in these specific patient populations. Examples of studies that are ongoing or upcoming are listed here. Finally, for all clinical trials, correlative studies should be optimized that define the biologic and clinical state of oligometastasis in a more sensitive and specific manner through blood and tissue analyses that can lead to the identification of high-impact predictive and prognostic factors. There are numerous contributors to thank for this study. These include my co-authors who are listed in the first slide and again here. I would like to acknowledge especially the research nurses and database management team, as well as scientific editor Christine Wogan, and of course the dedicated patients that gave their time to this study and who are the true engine and inspiration for prospective clinical research. Thank you.